So this webinar today is entitled Establishing and Maintaining Diversity, Equity, and Inclusion Committees, something that I know there's been a huge amount of email traffic on and interest in across our system. As I mentioned before, this webinar is a collaboration between a VA section of Division 18, as well as the AVAPL Psychologists of Color and Ally Special Interest Group. And we want to thank you for attending today. We know everybody's busy. For those of you who are interested, 1 hour of CEUs is provided. If you are a Division 18 member, that is free. If you are not a Division 18 member, then it is a small fee of $15. We'll tell you more about that information at the end. Questions can be answered in the Q&A chat box. I will try to do my best to keep track of that. Asale, I might feed them to you as they come up, if that's all right. If there are any technical difficulties, also please let me know that in the chat box, and hopefully Dr. Fennell in the background can assist with that. So with that, I want to go ahead and do the introductions of our esteemed panel. Our moderator today is Dr. Asale Hubbard. She is a staff psychologist and integrative behavioral health director at the San Francisco VA. She is a diversity, equity, and inclusion trainer for UC San Francisco School of Medicine and a member of the VHA Race-Based Stress Trauma National Consultation Team. She also serves as the social media chair for the AVAPL Psychologists of Color and Ally SIG. Excuse me. Dr. William Hua is a clinical health psychologist also at the San Francisco VA healthcare system, where he provides behavioral medicine and integrated care services for veterans living with HIV, as well as liver care concerns. He serves as the chair of the Psychology Diversity Committee and staff lead for the Acceptance and Commitment Therapy Clinic and Learning Group. Dr. Kaela Joseph, we have a whole bunch of folks here, is also from the San Francisco VA. You all are leaders, obviously, across the system. She is a staff psychologist and the Women's Veterans Program Manager at the San Francisco VA. She is a director of the Trans Health Clinic, which houses primary care, endocrine, mental health, and social work services for transgender and non-binary veterans. Dr. Danielle Lespinasse is a clinical psychologist at the Philadelphia VA. She works in the Behavioral Health Lab, affectionately known as PCMHI to the rest of us, and is co-founder of the Behavioral Health Diversity Team and co-chair of the Diversity and Inclusion Executive Committee. And last but certainly not least is my buddy, Dr. Josephine Ridley. She is the Assistant Chief of Psychology at the VA Northeast Ohio Healthcare System, also known as the Cleveland VA, serves as the program director for the Clinical Psychology Postdoc Residency. She chairs the Psychology Service Diversity Committee and serves on the AVAPL Psychologists of Color and Ally SIG Mentoring Subcommittee. Thank you all for your amazing work, and I'm going to hand it off to you, Dr. Hubbard, to take it away.
Thank you so much, Gail, and please let me know for any reason you're not able to hear me. I am really excited for our conversation today, and in preparation, we put together a bunch of questions that we have seen come up over time, and then we'll have some time at the end for any questions from the audience. So we'll go ahead and get started. And really to start off this conversation, you heard a little bit of background about each of the different panelists today, but we thought that we'd go around and just very briefly talk about what does a DEI committee look like at your specific facility, and what were the steps to get it established. If each could share briefly about what that looks like. Dr. Ridley.
Yes. So it would help if I unmute myself, right? So I was saying, I don't mind starting because I'm the oldest, and they say age before beauty. So I don't mind. So the way that we got started, first of all, was in response to an APA Commission on Accreditation site visit for our residency program. So in 2013, they came, and the first thing that the then residents complained about was the lack of diversity in the staff. Our VA services predominantly African-American veterans, and there's a tremendous, like, overt lack of diversity amongst our staff. And so not only did the site visitors note that, but the residents themselves, our psychology residents, were complaining about it. And so one of the things that we were cited about at that time, and even got a 5-year accreditation rather than a 7-year at that time, was because we lacked diversity in our staff, and we did not have real clear steps on how we were going to improve that. How were we going to recruit and retain diverse staff is one of the things they required of us. How would we also measure multicultural competence in our residents and trainees, and how would we make sure that our staff were multiculturally competent as well? And so our, at that time, our training committee recommended to our chief, our psychology service chief, that we really needed a diversity committee. So the chief initiated, and he did approach me because he knew that I was very outspoken about issues related to diversity. I often did seminars related to diversity. So he approached me and asked me to become the chair. He asked every single ethnic minority person or a person with disability on our staff. At that time, we had 2 people with overt disability, and one of them was asked to be on the committee. And we had only one Asian American. She was asked to be on the committee. So it was like 5 of us out of a staff of 100 and something psychologists. And so the 5 of us started the committee. I was the chair of the committee. And the first thing we did was draft a charter and come up with our mission statement and purpose and all of that, which I'm more than happy to share. Since then, the charter has expanded. And initially, we started off with just people who represented diverse populations. Now, today, and so our first meeting was in 2014, March of 2014. Today, we are at 12 staff members. Or 12 members of the committee. And back then we only had 5. We don't limit the number of people who can be on the committee. We have very clear tasks that we are tasked with. It is just a psychology service diversity committee, so it's not for the entire the medical center. It's just for psychology service. We started a diversity grand rounds. We started a newsletter. We have had input into the curricula. We've for the didactics, we've had some input in recruitment and interviewing panels and things like that. So we've done a lot, and we still got a ways to go. And I also need to make an announcement. And so after starting this committee and being a part of it since 2014, I'm finally handing over my chairpersonship to a colleague of mine who's very active in APA and APIC, and she is a person with a physical disability. And I think she's going to do a great job, but I wanted to be more present on the national level with you guys and to be more active that way. So I thought, well, I can hand this over and give someone else a chance to be the chair. So that's my announcement. It's just effective as of tomorrow, September 1. Okay.
Thank you so much, Dr. Ridley. And for other 2 facilities?
Hi, so I'll jump on after Josephine. So similarly with Cleveland VA within Philadelphia, we started with our psychology training program. The accreditors were coming and we wanted to reflect on, what offerings we had. And so we started to look at how to improve cultural competency didactics within psychology. And through that, our future chief was on the Behavioral Health Executive Committee. And so when discussions started about wanting to improve diversity and inclusion within the whole behavioral health service, my name and the name of my colleague who had been assisting with improving the training program came up. And so our committee is for behavioral health, so psychology, psychiatry, social work, and behavioral health nursing. And our 3 aims, which we started into in 2018, was to improve hiring and retention of underrepresented groups, provide training and education related to cultural competency, as well as consultation for providers, and do marketing, so a newsletter, like Dr. Ridley talked about. So we, as a diversity team, are on the panel for psychology hiring. We have provided questions related to cultural competency for the interviews for trainees, as well as for staff psychologists. And then we have a team, and our social work department has a team at the Philadelphia VA. So we discussed having a hospital-wide committee, which was championed by the chief of social work. And we have a PENTAD member who is our executive champion. And the one person from social work team, one person from behavioral health team came together. We're the co-chairs of that executive committee for the hospital. And we have similar aims as the Behavioral Health Diversity Committee with regard to hiring and retention, education, and communications. And then we also added a measurement component to see, quantitatively, how can we improve outcomes in the hospital, whether it's staff and patient satisfaction, or on measures like the Human Rights Campaign hospital survey that they do annually. So that hospital-wide committee has been here for about 1 year, and we have 15 or more people on that committee, including the chief of staff, chief of patient care services. So really wide variety of people all around the hospital represented on our committee. Thank you.
I'm happy to represent San Francisco VA, and I wanted to acknowledge that there's a lot of folks, past and present, that really are part of this committee and that have been part of the formation. And I think sometimes as a representative, too much credit can be given to one or a couple of individuals. So I want to acknowledge all the folks that are part of the committee here in San Francisco. My understanding of the committee in terms of its original formation over 10 years ago was that there were a couple of postdocs, including Don Lahan at the time, who later became a staff member with us for many, many years, who wanted a more formalized part of diversity, equity, and inclusion training in terms of their postdoctoral fellowship, and partnered up with several staff members to form the initial committee. And really, sounds like they focused a lot on case discussions and talking about instilling inclusion and equity work into their clinical work. In that time, we've expanded quite a bit, and as it stands currently, our Psychology Diverse Committee has 5 subcommittees and several task forces. How those were formed were, based on just expressions of interest from staff members and trainees, as well as informal and a little bit more formal surveys that were sent out to folks in terms of what is needed here at our VA to really be an inclusive environment. So some of those subcommittees really tackle kind of the range of diversity and equity inclusion programming that we want to consider. So a sampling would be one of our subcommittees is around providing consultation and resources, developing a database of resources for people to access. And then another one works on doing things like this, developing seminars and webinars and guest speakers so that we can have programming and celebrate, various identities and heritages. We have a PR and community outreach subcommittee that works to disseminate information about what our committee does and creates the newsletter. We have a new staff diversity development subcommittee, which works specifically on training activities for staff in terms of development of inclusivity in their work. And then we also have a training liaison committee that works to make our work more systemic, along with the training committee as a large, making sure that we're thinking through this from the extern, intern, and fellowship level. Ours is a voluntary committee, so it is open to all staff and all trainees. I think we have over 15 or 20 staff members who are relatively active, and over 30 trainees who are at the extern, intern, and fellow level. We don't have specific membership requirements currently, although we are considering ways of adjusting that. And then we have monthly meetings for an hour, and then monthly subcommittee meetings outside of that. So pretty large committee, and as I mentioned, currently voluntary in terms of, not a mandate, or I want to talk in a little bit about kind of some pros and cons of mandated versus voluntary committees, but happy to be representative of our community today. And it is specific to psychology in terms of our committee. We have a larger mental health diversity council, which is separate from that in a larger VA-wide committee, but this one is specifically for the psychology section.
And one of the committees at San Francisco that I'm representing is actually one of the mandatory committees. So in addition to being on the Psychology Diversity Committee, which I joined as a resident, I'm also on the Women Veterans Health Committee, which is a mandated committee that all VAs are supposed to have, and even the membership is mandated. So we have that committee open to whoever wants to join, but there are specific people from each department that we have to have represented. And that committee is tasked with some very specific things for the Women Veterans Program in terms of making sure that care to women veterans is equitable. We also have a mission right now to try and bring more intersectionality into that committee and make it not just about gender, but all of the different identities that intersect with gender and create an equitable healthcare environment. So that's one of the committees that I'm representing. The other is the special interest group, the LGBT special interest group and allies for AVIPAL. And so there, the focus is still on intersectionality, but specifically looking at less apparent identities like sexuality and in some cases gender as well.
Thank you so much to each of you for sharing. And I think one of the things that we wanted to do just to start was give kind of a really kind of broad overview of these committees. And I think already we're kind of seeing a lot of variety and diversity in terms of how these things can look. And so it's really, you know, going to be about kind of what makes sense for you and your facility. But we have some more pointed questions that hopefully will address some of the questions that we're already seeing here in the chat and the Q&A. So in moving forward, let's talk a little bit about what the primary mission and goals are for such a committee and who really should we be thinking about in terms of membership. Dr. Ridley, could you speak to that a little bit?
Sure, I remembered to unmute myself this time. So I would say you hit the nail on the head, Asale, when you said that it's going to vary from VA to VA. So the mission is going to be based on what is needed at that VA. If you're at the Hines VA, your needs are going to be very different from Iowa City VA. And you're going to have a different group of providers to pull from too. I mean, Hines is probably a lot more diverse than Iowa City VA. And so when you talk about who might be a member of those committees, it's going to depend on the needs of that particular medical center. So our diversity committee came about as a specific need in response to what APA found deficient in our department. And truthfully, I just commend APA for always stepping up and really trying to be present in the move towards multiculturalism and inclusion. And I think if it wasn't for them, we probably wouldn't have a diversity committee right now. Our mission is very specific at our VA. Our task was to improve recruitment and retention of diverse staff. It wasn't really even though it came from the site visit, it was really focused and targeted on helping with recruitment and retention of staff. Then the secondary task was to really help in educating our staff to be more multiculturally competent and inclusive. And so we've really taken that mantle on and have actually started our diversity grand rounds back then, and it's been flourishing, and we've actually had an impact on how our staff are delivering didactics, and we've had an impact on even how our staff are evaluated on peer reviews, et cetera. And we still have a long ways to go. So I think the mission's going to be different, and who's going to be a part of it is going to be different. So since it's in our psychology service, anyone who's a part of our psychology service can be on the committee, including trainees, and we've had a nice representation. We started off limiting the trainees to one intern and one postdoc could be on the committee. Now we allow whomever applies, and we do have an application. The reason why we have an application to our diversity committee is that the committee members agreed that you needed to demonstrate some level of competence already, that you had some commitment to multiculturalism and diversity and inclusion. And we felt like if somebody actually went through the trouble of filling out an application and turning in their CV, they were showing some level of commitment from the jump. And it doesn't matter how small or how few people are interested. If you've got people who are really dedicated to this cause of improving the ability for people of color and people who have disabilities and people who are LGBT communities, people who are disenfranchised, if you have that dedication and commitment, then it doesn't matter how small your committee is, you're going to make a big difference. And you're right, you do need buy-in from leadership. And fortunately, we had the power of APA backing our buy-in ship, and that really helped tremendously. And so there's lots of ways to get it started. But again, I don't think there's one specific purpose other than the improvement of diversity and equity and inclusion at your medical center or within your service. And nothing is too small, everything counts. I mean, we have potlucks, we have multicultural potlucks where people can bring in their, Boston baked beans and talk about their culture from Boston. We have all kinds of meals that are brought in during that. Of course, during the pandemic, we had to cancel it this year, but so there could be all kinds of events that can bring the community together to appreciate diversity, but also to pay attention to it. And with that, I'll pass.
I think it's really interesting what you were sharing about that. It kind of started from this place of staff and how it's kind of evolved to include more trainees and just a wider array of people as part of this. And so kind of thinking about that, next question, for Dr. Hua, what do you see as some pros and cons of having a committee that's mandated versus voluntary?
Thanks. Yeah, I definitely think that context matters. And I think it really comes down to what Dr. Ridley said in terms of what works for your committee. And I think in general, an openness to be shaped and to change over time, and maybe the needs of the committee changes. Our committee isn't mandatory, so I'm going to speak kind of from a hypothetical perspective, and happy to have Dr. Ridley jump in. But my guess is as to what really benefits from a mandatory or an application-based committee, like Dr. Ridley mentioned, is that you might have more commitment and you have more clear expectations for involvement. If you're going to be applying and it's a part of your practice and part of your protected time, perhaps it's going to be that there's these clear expectations for your involvement and a clear dedication. I think there may also be less potential burnout if everyone who is part of the committee, who is engaged and has a consistent presence, they're going to be more involved and have contributions in that way. But again, these are just kind of what I would imagine are parts of kind of more expected expectations and clear boundaries for some committees. For us, our volunteer committee, I think it's true. I think that both voluntary ones and mandatory ones can have more potential participation engagement, but again, it depends on the context. I think by being voluntary, it allows each person to do a bit of a self-assessment of what can I contribute based on the plethora of my other responsibilities. And I think this is especially important for people of color or folks from underrepresented identities, whether visible or invisible, where we know that minority tax and minority burden is a very real thing. So in voluntary committees, I think there's that benefit of each person kind of deciding, given my current burden, given my current minority tax, or what responsibilities I have, I can kind of step in, step out in that ways in which it can help, particularly underrepresented identities and people of color in that way. So I think both could also contribute to less burnout if more folks are volunteering because of a larger opportunity to share in terms of engagement. And I think it's true for both types of committees. I think it can have more or less trainee involvement depending on. So again, having a mandatory or having an application based, the trainees are, have clear expectations, they're signing up for it, they have consistent contributions, but then maybe having it voluntary, they can kind of be more involved the first 3 months, for example. Maybe they step back on a rotation whenever they feel not as free to do so. So I think pros and cons to both. I think they probably can be worked out in many different ways, but I think it does matter the context in which the committee is taking place. And I think in general, no matter what, being open to being shaped by feedback, by being shaped by new information or new perspectives, and being able to change your committee accordingly as a way to be shaped by that feedback.
Now, one of the things that's kind of already come up as people are kind of talking about how their committees came to be is people kind of getting tapped or asked to be part of this work or chairing this work. And so wanted to talk a little bit about how the idea of tokenism or colorism shows up in the creation of these committees. And Dr. Lespinasse, I was wondering if you could speak a little bit to this.
Sure. So, you're all here because you either have committees already or have been asked to or encouraged to create these committees. And creating the committees are great, but we don't just want to make a committee, we want to make an effective committee. And so we have to think about, how can we get them to work? And we know that what doesn't work is when a diversity committee is set up only as a symbol, as a token that just says, yes, we have a committee, but there's no resources, no time or attention devoted to the committee or its members that are working hard to affect change. And this is really where that idea of tokenism comes in. It's the practice of doing something only to prevent criticism or give the appearance that people are being treated fairly. So this can show up as hiring people of certain underrepresented groups just to say, oh, we have one of those. Asking someone to represent their entire traditionally underrepresented group, having a committee that we, again, devote no time or resources towards, doing a single annual event. And so sometimes, if there is only one person who identifies as a racial, ethnic, disability, gender orientation, minority status at a facility, sometimes that's the person that's asked to head this type of committee. And so that person might feel both internal pressure to put this together and external pressure from the department, whether or not they actually have the time, experience, ability, headspace, emotional space to do this type of work. So tokenism, gives the appearance of equality without actually achieving it. So, when thinking about creating these committees, the ways that we can prevent tokenism are by focusing on diversity, equity, and inclusion. So we need diverse membership within our facilities. We need people to be given equal access to resources and to ensure that all members, no matter their background, feel welcomed and valued within our organization. Thinking about, do the people on the committee really have a seat at the table, or are they just figureheads for diversity? Are we hearing their voices? Just to speak to colorism a little bit. So for those who aren't aware, it's the practice of differential treatment of people of the same race who have different skin colors, often with preferential treatment for people who are lighter skinned than darker skinned. And that's due to the proximity of the lighter skinned individuals to whiteness. So especially when we're talking about having difficult conversations about diversity, equity, and inclusion, you may find that this practice of colorism exists. So within your facilities, looking at, who's being asked to lead these committees, who's being listened to with regards to these efforts. And it's highly likely that there are many people of color and other minority statuses who've been trying to make these efforts happen for years. People who've encountered roadblocks, leading to frustration and disenchantment by the lack of support from leadership. So thinking about what can we do? How can we engage these people? Within my organization, our social work committee was established a couple years before the Behavioral Health Diversity Committee. Our social work team is predominantly Black and African American individuals. And so what we've really tried to do is talk about their efforts, learn from their best practices, figure out what their setbacks have been, and try to amplify everyone's voices, especially the people of color who perhaps have not been given that voice in the past. And so it's really important for us, all of us on diversity committees, to try to pull people into the conversations that perhaps have been left out. So those are some of the potential impacts of tokenism and colorism.
Really appreciate you sharing those thoughts. And I think one of the challenges that we've heard from people at many facilities is potentially not having, kind of well-represented, staff in terms of different, whether it's racial and ethnic, sexual orientation, gender. And curious for you, Dr. Ridley, what are your thoughts about those who don't identify as being people of color chairing or even, leading these committees or even subcommittees?
And that's an excellent question as well. And I would go back to, this has become my standard answer. It's going to vary from VA to VA because out of necessity, if you're in Portland, Oregon, in the VA and it's all white staff, I mean, there's not going to be a person of color who can be the chair of that committee. And also to piggyback onto what Danielle said, we don't want tokenism, and we don't also, and this is something that Will said, that we don't want to put a burden, a tax burden on people of color to always be that representative. Just because someone is a person of color does not make them an expert in multiculturalism. It does not make them an expert on all things diverse, and they may not even want to operate in that role. So I don't feel that it absolutely has to be chaired by a person of color or a person from a diverse population to have a diversity committee. I think it's more important to have a diversity committee than to have it chaired by a person of color or a diverse population. That being said, if in my VA, if with people knowing how much of a strong advocate I had been for years, and I mean, this goes all the way back to my childhood, really, of always being very present in the conversation on race and racism in our country, and always pushing to have a cross-cultural competence, a multicultural competence pushed in our training programs. If I had to compete with someone who was not a person of color and not a person from a diverse population for that chairship, I would feel a little bit slighted because that's my area, and this is something I would want to do. But I would say not to focus as much on that as much as just getting the diversity committee up and running and being committed to it and being open to the difficult and uncomfortable conversations that come with talking about oppression and comes with talking about inequity and that it exists. And one of the frustrating things about, and I'll just share, this is personal and I know it's being recorded. That's the thing about getting older, you just stop caring about certain things after a while. But I'm just going to put this out there. One of the most difficult things, and I know I was going to talk about this later too, but is to have people say, why do you always have to talk about race? Or why do you always have to have these topics? And it was interesting, my diversity grand rounds, the majority of the topics that were well attended initially before this year were the topics on LGBT community. The most poorly attended were those that focused on African Americans, and those were the rare events that we had. Most of our events were more focused on LGBT community. So that was just kind of astonishing that people were seeing it or perceiving it as being overly done when it was actually the fewest number of sessions and the most poorly attended. And let it rest at that.
It's really important. And so kind of what I'm taking away from what you're saying is that kind of no matter kind of what the current setup, it's better to have, a committee and to work towards that rather than to say we have to wait till, till X staff member, gets on staff to
Exactly.
do that.
Exactly.
And we know that, oh, sorry, go ahead.
No, I was saying exactly. I was agreeing with you.
We know that too, there's already kind of established kind of entities within the VA system that are, really targeted at supporting particularly experiences that people have. And that's EEO. And so, Dr. Joseph, could you speak a little bit to what your experience has been in terms of interfacing with EEO and how that might look for these committees?
Yeah, so similar to what everyone else has mentioned, with all of these different aspects of diversity committees is it's going to vary from VA to VA. So one of the things as we were planning that I was hearing about were experiences with EEO where folks were told, no, EEO does diversity. You can't use the word diversity, or you can't have this committee because EEO does this. That's not been the experience that I've had in working with EEO. In fact, if anything, I've had sort of the opposite experience of our EEO not being strong enough to do some of the things that it's supposed to be doing, and therefore our diversity committees, not just the psychology diversity committee, but some of the others in the hospital end up picking up some of that slack, sometimes where it's not really appropriate to. And so I think the most important aspect of that is that there is collaboration with EEO and that there's a clear delineation of who's doing what and what exactly EEO's role is, what exactly a diversity committee's role is. One of the unique things that we've benefited from with our EEOs are special emphasis programs in terms of being able to partner with them to put on events so that we don't have to rely on really what is a lack of funding for a lot of these kinds of committees, whereas EEO has some money set aside for the special emphasis programs. We've been able to partner to do things like be able to get a booth at Pride, for example, or be able to put on an event where we could actually have food from the canteen, which gets more people involved. And so I think there's also some creative ways to get involved with EEO, particularly the special emphasis program managers.
It's really helpful to think about that interface, and also really clearly kind of delineating, you know, the nuances and what roles each of these serve. And so, you know, everyone that's here has kind of obviously had some success with getting one of these committees together, and, you know, have seen some longevity with this. And so one of the things I think can be hardest for people is ultimately, if there is this interest and momentum, you know, how do you actually get leadership to buy in that this is something that you need to have at your facility? And Dr. Hua, I wonder if you can speak a little bit to this in terms of how to make that happen.
Yeah, I think that we've kind of always had really good leadership buy-in in the beginning, to be honest. But I think of leadership buy-in more generally as organizational buy-in, because beyond the leaders of a mental health department or psychology section, you're really talking about the VA as an organization. Are we being anti-racist? Are we being anti-sexist? Are we being anti-misogynist? And all these different ways in which the system is doing that. So I'm a firm believer in the build it and they will come piece of things in terms, and I think a lot of folks have kind of shared that in some ways. It's that, you know, maybe you start small, maybe you start with a case discussion or a seminar or a guest speaker, but you know, build it and folks will come. You know, I'm looking at the number of attendees here today, 160, you know, and that's, you know, a lot of the great work that's been put on by this division and the moderators to put this together, and folks will come. Folks are interested in this, folks are passionate about it. I think we just have to create the spaces for people to have their voices be amplified in that way. So again, I think starting small is important, and you know, I've done some consulting with some other VAs around when there isn't as much leadership buy-in or organizational buy-in. I think that's the importance of having some data, so sending out surveys, getting data from folks, getting feedback about what's needed, what's desired, what isn't there, what is there. And then I always say document every effort. Every program or speaker or webinar you put together, document how much time you put into it, document how many people were involved, document how many different clinics and programs were involved. And those types of information are really helpful to kind of show, even just putting on this one webinar that was attended by 160 folks, this is the time that was put into that, and this is the impact that we had. So keeping that data is really important. I think of good leadership as equitable leadership. So really good, strong DEI spaces help everyone. It helps everyone to be more social justice oriented, helps us to be better clinicians, leaders, administrators. So I think part of this for me is gathering the community, figure out what folks are passionate about, and put that passion into, you know, we form a lot of new subcommittees here whenever someone brings up a really great idea and we say, oh, we don't have that yet, but you're really passionate about it. Let's create a new subcommittee. And then creation of that ongoing data collection, ongoing feedback, to where, you know, you're making the individual efforts the goal is to make it more systemic. You know, we're happy to say that after some years here, we've been able to create some diversity performance standards that are now required for all staff psychologists in terms of diversity, equity, and inclusion performance standards that involve cultural humility, self-awareness, information about the ongoing supervisory relationship, and commitment to ongoing training. So again, I think the larger message is start small, and as the snowball kind of continues and gets bigger and bigger, I think it's finding ways that the organization can see those efforts and see the impact it's making. So regardless of the kind of the makeup of the committee or the context of the organization, I think it's about starting somewhere, as Dr. Ridley and others have mentioned as well.
Thanks, Dr. Hua. And I feel like we've gotten a lot of information about, you know, some of the positive things that people have been doing on their committees and subcommittees and the things that have been able to happen. But we know that this process is not one that's always all of that smooth. And so we also want to talk about actually what are some of the biggest challenges with these committees, and what are some of the things that you've been able to do to overcome them. Dr. Ridley, can you speak to that a little bit?
Sure. I kind of hinted at what I thought was one of our biggest challenges, and that was getting the people who really needed the training to attend the trainings. So when we would offer the diversity grand rounds to all, to the whole medical center, but really focusing on behavioral health professionals, getting the psychologists who were not psychologists of color to attend was really difficult. It was almost like, you always get the audience members who already are the choir. They already are committed, and not the people who really needed to be there. We still have a large group of psychologists who don't feel like social justice has any place in psychology. They feel like it's political and should not be involved in psychology and what we do as psychologists. And so to still be having that conversation. And this is something that I've noticed when you think about counseling psychologists versus clinical psychologists. In my clinical psychology program, we weren't trained to look at diversity issues at all, really, not at all. And social justice, we never even heard that term spoken in my department. Whereas in counseling psych, it's always been included or invested in. So here in our medical center, I remember for the Psychology Training Council's diversity and inclusion committee, when they were having their discussions, their diversity discussions, and they put out the question about social justice, I had the little discussion here as a part of our grand rounds, and there was so much dissension and so much disagreement, and that people were like, you don't need to bring in social justice. That's just political, and we're not supposed to be political. And so it's so interesting after George Floyd's murder to see people now pursuing the conversations, people who previously felt like I was bringing it up too much, I was bringing race up too much, I was presenting too many seminars on race and racism and PTSD and racial trauma. They didn't, why don't I talk about other stuff? I think it was interesting to see so many people now wanting to have that conversation. So my biggest struggle, I would say, was getting buy-in initially, and also not being treated like we're the police for diversity, like we're trying to enforce it. People still see us that way. So it's this negative presentation when we're coming to have the discussion, or if we are trying to give feedback on didactics. And we're not trying to be the police or enforce anything. We're trying to make sure people have the understanding of the importance of it. And I think most of you who are starting diversity committees, you may run into that difficulty of really explaining to people why it's necessary. Although in light of what's happening in our society right now, it might be a little easier for you than it was for us 6 years ago starting our committee. That because the conversation is so prevalent now. And I've just been really encouraged by the fact that so many people are willing to have this difficult conversation now, when it has really felt pretty lonely over the past 6 years or even beyond that, to have it and to have people openly talk about it. Which is unusual for psychologists if you think about it. But the fact that the term social justice can now be spoken openly, the fact that our chief actually put out a statement and had a moment of silence for the time that George Floyd was losing his breath. And I mean, all of those things were unheard of before. You just weren't supposed to bring up anything that was controversial, and now to actually be talking about these things. And I think it's just interesting, because if it was childhood sexual trauma, we'd have no problem talking about it, and we could put it out there, and we could have sessions and training sessions, and everybody thought that was great for psychologists to talk about, but we can't talk about racial trauma. So that was, it just seems like there's been a transition. But yeah, getting buy-in from not just leadership, but from the people who really need the training, the people who need to really have the conversation and know why it's important for our veterans.
Now, we've been primarily talking about this, in terms of psychology committees. And this next question, I'm going to split up a little bit. Dr. Lespinasse, if you can talk about what you see as the pros of having these types of committees at different levels of the organization. So, department-wide or facility-wide. And Dr. Joseph, you could speak to what are the things that you see as a con of splitting up or having multiple committees on different levels.
Sure. So, like I mentioned, in Philadelphia, we have both a behavioral health service and a facility-wide diversity committee. And so some of the pros of the psychology behavioral health service committee is that we all conceptually have similar training to talk about these types of issues, to talk about implicit bias, to talk about power and privilege. We have clinical skills that we hopefully can use with ourselves as we explore and self-reflect on things that we're bringing into the therapeutic environment. And so because we have a smaller range of services that we provide, also it's easier to find a target for the committee because we're all sort of coming to the conversation with a similar background. With regard to the larger committee within our hospital, the pros that I've seen are that we can affect broader change. We have people with skills from all different types of departments on our broader committee that understand different systems all over the hospital. And so while in psychology, you know, we have RVUs we have to meet and amount of clinical time that we have to have, there are other people within the hospital who their job can be to integrate this into their job. So the education department, the women veterans coordinator, the LGBTQ care coordinator, the transgender team, the minority veterans coordinator, these are already people who have administrative time where they're joining the committee, they can really integrate some of the things that we are hoping to get done into their job, and they don't need protected time to do it, which we'll talk about later. And then lastly, with a broader committee, you can also align the diversity committee's goals with the missions of your hospital. So within Philadelphia, as with many other places, we're rolling out whole health. So we can think about how can we incorporate culture into whole health. For anyone who's seen the PHI, you know, that has relationships and spirituality and power of the mind, power of the body, culture can be laid on top of all of that. Someone who has a disability, that's laid on top of all of that. And how can we be thinking about how to incorporate aspects of people's identity into the whole health model? How can we think about having a high reliability organization and the ways that diversity and cultural competency impact our ability or disability to do that? And then lastly, with relationship-based care, which is the third initiative that we're putting out in Philadelphia. So care for the self, care for the colleague, and care for the veteran. You know, you can't have any of that without trying to understand where other people are coming from and understanding their history, what's important to them and their values. So really, you know, I think the larger committee allows you to align yourself with some of those hospital-wide goals that can show up on SAIL metrics and all those other things that leadership is really focused on.
And I think one of the cons that comes to mind is when we have so many committees. This is what I've seen at our facility, is when you have so many committees, you might have folks doing double work. And so you have that same kind of emotional labor tax that we were talking about earlier, where you have a lot of the same people involved in most of the committees, but then also just people doing the same things in different committees and not necessarily coming together. And so it can take longer to get change going, or it can be easy to feel like, oh, well, we were working on this and this is our thing. And so I think similar to what I talked about before with those clear expectations with EEO, if there are multiple committees, it's really important that it's clear what is the mission statement of each and what are the things that each is working on. I think the other piece is representation of diverse staff who are not clinicians. I think when we look at a lot of hospital-wide committees and a lot of service-wide committees, there's less representation from frontline staff, there's less representation from places like engineering and other services throughout the hospital. And so I think it gets easy to think of things from a clinical standpoint and to forget inclusion of those other services.
You're already kind of talking a little bit about time, and so I'm curious, so a couple things, I'm going to kind of split this too. Dr. Joseph, you can talk about, you know, how do we actually get time, you know, labor mapping really to be able to do this work. And then Dr. Hua, if you could speak to that piece related to the kind of the load, disproportionate load that's often placed on people of color in doing this work.
Yeah, I think getting the labor mapping relies on having supportive leadership. So if there's supportive leadership and it's not interfering with other tasks, then the labor mapping seems to happen, or at least be championed in a more meaningful way. I think it becomes a little bit of a double-edged sword though, because there's always more work to do. It's the way that our system is set up as a larger system. And so I'm in one of those fortunate positions where I am labor mapped for this because my whole role as a Women Veterans Program Manager is DEI focused. And so I have a plethora of time according to my RVUs and the way that my productivity is tracked. And I don't actually have that time in reality when it comes to all of the different things that have to get done. And so one of the conversations I know we've had in some of our committees is the labor mapping is fantastic, but there also needs to be enough staff present that you're not looking at your labor mapping and saying, well, I don't have to take this patient, for example, but am I going to turn this patient away to get this other task done when I know that there's nobody behind me to see that patient? And so it's not just the labor mapping, but also making sure that you have a well-rounded enough staff, that you have clerical staff so that you're not doing clerical work in addition to your clinical work, for example. There's a lot of overlapping pieces with getting time and not just the labor mapping.
I think for me, this is around shared responsibility and making sure all of our communities are really stepping in and stepping into this work and allowing those who have been doing the work for a while to kind of also be able to step back. I think it's about being really intentional and mindful of the higher level of burden on particularly Black and Indigenous staff and people of color, and how, you know, with the recent killings, I think there can be this tendency to think, oh, now is the time to do this diversity and equity and inclusion work. But for Black and Indigenous communities, the time has been for a long time coming, and the burden placed on them to do this work hasn't been happening for a really long time. So this isn't a recent or current systemic racism kind of problem. This has been going on for a really long time. So I think part of it is that when folks ask, you know, staff of color or trainees of color for something related to like a presentation or starting a committee, really having to be thoughtful around, can I find this information out myself? Can I work with my colleagues to get this information? Do I need to be asking the staff of color or the trainees of color to participate in this way? Really being thoughtful and intentional about our intentions around that. And I think this is where the shared responsibility and shared community comes in. We have to create spaces for staff of color, trainees of color, white staff, white trainees as well, to be able to do that. And part of that is systemic ways in which diversity committees can be maintained. And that goes into things that folks have been talking about today, including protected time, protected spaces, safe spaces. We currently don't have term limits for our chair and subcommittee lead positions, but it's something that we're thinking through, and one of our staff members have brought that up as a way to help us sustain ourselves and maintain the work that we do. We currently have 1 chair and 8 subcommittee leads. So part of that shared responsibility allows us to kind of sustain this work, but being able to kind of really think through how does the community and the committee sustain itself. So another idea that we're entertaining right now and moving forward with is having more than 1 chair of the committee, for example, and then that way the shared responsibility and the shared work is more intentional. So hopefully that helps to kind of decrease some of the burden on individual folks that have extra burden for them, even given all that's going on. So hopefully sharing that space.
Now we're hoping to get to maybe 1 or 2 questions before we wrap, but I think kind of big picture, and thank you so much panelists for all of the questions. I know it was a lot of questions to go through in a short period of time, so thank you so much. I hope this has given everyone kind of a sense of some things, Lisa, to think about and some resources that might be helpful. Want to talk a little bit about what's happening nationally, as well as any resources that we can direct people to for more information, whether it's things like charters or other things that people might consider. And I was wondering if Dr. Iwamasa or Dr. Lespinasse could talk a little bit about what's out there.
Yeah, so Dr. Iwamasa and I are working together with a team to put together a SharePoint that will house charters, it will house agendas, meeting minutes, calendars, anything that people might need to help put together a diversity committee. So we're collecting resources. So if any of you on the call have a diversity committee that started already and would like to share these types of resources with us to include, that would be wonderful. You could email myself and Dr. Iwamasa with that information. Another resource that's available nationally is that Dr. Edmonds, has put together a monthly meeting where people who want to start or have recently started diversity committees can meet to talk about progress and ask for support. And the next one is coming up on Monday, September 21st at 3 p.m. Eastern Standard Time. So you can email Dr. Edmonds if you'd like some more information about joining that call as well. Dr. Iwamasa, I don't know if there's anything else you wanted to add as well.
Sure, I see in the Q&A some folks have questions about resources. Hopefully that resource library will be up sometime in September. That will be housed on the VA Office of Resolution Management and Diversity and Inclusion. So it's not within VHA, but it's actually at a higher level because diversity and inclusion, as you heard all these amazing presenters talk about, really goes beyond mental health and goes beyond healthcare. You heard Dr. Joseph talk about the importance of other folks at the facility level being involved because honestly, inclusion really means inclusion. It means everybody, everybody in the workplace, and we need to strive for that. And so they are revamping their website, and so it's great to be a part of that. Also be aware that within mental health, my office, Mental Health and Suicide Prevention, has launched Discrimination, Bias, and Equity Resources SharePoint, so please take a look at that. I know it looks like Christina Garcia, you asked about external resources. That site links to tons of other external resources. Dr. Hubbard has just updated the POC and LI-SIG webpage on the AVAPAL website, and she's done an amazing job there, and that has tons of resources as well. So things are in the works. It looks like there's a question from Alan Marcus about sort of grassroots efforts, if that's something that's going on. We certainly hope so. We heard Dr. Ridley talk about that. You know, it just takes a few people to make a difference, and now is the time. Having said that, I do believe that senior leadership in VHA understand the seriousness of the need to be more inclusive and equitable, and there are currently efforts underway within VHA to develop a diversity and inclusion office. And so hopefully you will start seeing some improved and enhanced, let's say, messaging and attention to issues of inclusion and equity across the system. You know, I remain optimistic about that. All right, Asale, I think it's time that we need to wrap things up. Thanks to you. You did a fabulous job moderating as usual. Those of you who are interested in receiving CEUs can do so by completing an online evaluation. Let me post this link in the chat in a minute. The CEUs are free for Division 18 and AVAPAL members. And so if you aren't a member, feel free to join. You'll get free CEUs as long as we have webinars. CEU certificates will be mailed in about 2 weeks. If you're not a member, that can be paid through the PayPal link. All right, 4 p.m. on the nose, folks. Thank you all so much for coming. Thanks to our amazing panelists. We really appreciate all your attendance. Thanks, everyone. Bye-bye.
Thanks, everyone. Bye.